Hello friends and welcome to the Physio voice. So today we are going to discuss a very interesting topic, that is the low back pain patient education. I call it as need of yeah. So all of you must be wondering, why did I choose this topic? The possible answers that must be coming to your mind would be that prevalence that every person experiences low back pain at some point in their life, or because we think we are doing it, that is why it is very important to emphasize on this particular topic. Or sometimes it is a very common scenario that patient pain is labeled as psychological if not treatable. Well, it is not so when we are dealing with a biopsychosocial model of pain. Definitely, psychological forms a part of it. But the real reason why I am discussing this topic today is because patient education is considered to be the first line of treatment for the low back pain. Okay, this is the first line. When I talk about or tell the statement, it is rightly supported by the evidence, that is Prevention and Treatment of Low Back Pain, that is published in Lancet in 2018, where education and self-care, that is the advice to remain active and education, is considered to be the first line of treatment for the acute low back pain as well as the persistent low back pain. Whereas if you talk about the other modalities like the superficial heat, exercise therapy or CBT, spinal manipulation, massage, acupuncture, yoga, they all have a limited use in the acute low back pain, or they must be having some conflicting evidence when we talk about acute to subacute and chronic low back pain. So the main emphasis over here is regarding the education and the self-care. Now, low back pain education. Have you ever thought that what patients are seeking in terms of not treatment, but in terms of the low back pain education? That what are we educating the patients and what are the patients trying to seek? What patients are seeking? What are the patients Googling? So I would call it like Google based. What are the patients Googling? So if you are the patient, you must be thinking that we are continuously Googling about the health information on the internet, identification of some serious pathology, principles of management, investigations to rule out the cause. So the patients, they are continuously Googling this information. So it's a common joke. When I'm feeling sick, I Google my symptoms and usually find out that I have cancer. The same was happening with us during the COVID, that we are Googling any symptoms and we are linking everything to COVID. So what happens over here is when there is a lack of patient education, the patient may get diverted towards a wrong diagnosis. And even after Googling, there is no satisfaction. Why? Because they find irrelevant and not trustworthy information on the internet. They have difficulty finding health information that varies in their quality, reliability, accuracy, as well as readability. And the information is inconsistent with the recommendations. Very important over here is the information that you are supposed to give to the patient in the form of a patient education should coincide or should be hand in hand with the recommendations, which usually does not take place. What's needed for the patients? So, before knowing what to tell to the patient, it is very important what is the need of the hour. What is the need of the patients? The patients also need a high quality, plain language and succinct information for consumers with low back pain that is consistent with the best available evidence. It's not that we have to distribute research articles to the patient, but we have to at least give the information that coincides with the evidence in a plain language which is best understood by them. Now, low back pain education. What are we providing? We are providing something that is knowledge based. Definitely, we have knowledge, and that is why we are able to educate the patients. But how do we know if we are making a difference? So, I call this term as the knowledge based. So, usually, what we tell the patients is about the ideal posture, or if their low back pain is acute, we ask the patient to rest. Or sometimes even in chronic, or maybe if you're young budding physios, you may advise rest to the patient. Or ergonomics, or put up a timer to just sit up straight, like sitting up straight with some amount of lumbar lordosis and your neck, back extended is considered to be the ideal posture. So we always tell the patient with this reminder to sit up straight. The fear factor. Now, who is fearful over here? The patient or the therapist? Don't bend. One of the most common and I would say the favorite form of the patient education in low back pain is don't bend. And next point is using the imaging for the diagnosis. So our diagnosis is going towards an anatomical classification where the anatomical classification for classifying low back pain does not work. But yet we are using imaging and exposing the patient to a lot amount of exposures to diagnose low back pain. But this is one side of the coin. The evidence is there even on the other side of the coin. So it's very necessary to have an insight analysis and look towards what the other side tells us. Before I come ahead with this, I would like to say you about the gap between the evidence and practice. It has always been a conflict what evidence is saying and what we are practicing. So there is a lot of difference between the research and the clinical practice. So this difference is called as the evidence transfer gap. And there is where somewhere where the evidence-based medicine is lying. So what as we physios have to do is to convert this research into a clinical practice and thus use this evidence-based medicine. I would give a disclaimer, I would discuss some articles, but it is just few of them that I am enlisting. I suppose that giving these articles or showing you these articles will help you to understand the other side of the coin. What is other side of the ideal posture? What is the other side of the ergonomics? So ignoring evidence leads to avoidable harm and failing to admit our uncertainties means we don't get better evidence. So it is very important first to accept a hypothesis and second, even if that hypothesis is rejected, we still accept it, we work on it. That is very, very important. So ideal posture, one of the fantastic studies that was done and published in the Manual Therapy Journal by Peter O'Sullivan about the ideal posture. So this study was done on 295 physiotherapists and 9 sitting positions were given and the physiotherapist had to choose that which was the best or the ideal posture or the optimal best spinal posture. So out of this, 2 positions, that is about sitting erect, were found that most of the physios are revolving around these 2 positions of around sitting erect, but nobody could reach to one particular posture. So this shows that there is a disagreement among the physiotherapists ourselves. And what are we calling to be the best sitting spinal posture? What are we calling as optimal? That is still a question. Second point is about the rest. In a Cochrane review, though it was done in 2005, this review had concluded that for people with acute low back pain, advice to rest in bed is less effective than the advice to stay active. So it's very important that we don't tell the patient to do a complete bed rest for more than 2 days. Then we advise them to be active in their normal routine activities. I will post all of these links in the YouTube channel below. Ergonomics. This was a very excellent clinical commentary that is set up straight time to reevaluate. So it tells us that ergonomics is not about maintaining a single ideal, correct, optimal posture, but there are different postures that are a way of life and change in the posture is the way to live. So change in the posture would help the low back pain, but maintaining single erect posture is not considered to be optimal. So there were certain few points that were given in this journal and regarding these points are very effective. Like sitting we consider to be very dangerous or we want everyone to fit under one frame. which is not optimally possible. So it was a very good article to go through. Next is the fear factor. There are even back pain beliefs of the healthcare providers that are being fear avoided. So it is found that if the therapist himself is fearful or is fearing of not educating the patient regarding the optimal posture, then what happens is it creates fear among himself. So what happens is we feel that maintaining the posture, not bending, is only the ideal way to manage the back pain. Well, it is not so. So it's very important that as physios we remove the fear factor from amongst us, and then it would help the patient. So this was an excellent study that was done, of which the reference I have quoted. Please go through. Imaging. Imaging, this excellent article that was done in George PT again, the appropriate use of diagnostic imaging in low back pain, a reminder that unnecessary imaging may do as much harm as good. So it concluded that doing unnecessary imaging, it is making the patient lot of it is creating a lot of self-doubt inside the patient, because the patient is seeing the interpretation of the reports, googling about the interpretations. It is even found in the last 10 years the rate of doing surgeries, the spinal surgeries, has increased of about 2 to 3 folds, and it is all because a lot of imaging that has been done. So the confidence in the patients is reducing. As physios, the diagnosis is revolving more around an X-ray and an MRI rather than the functional diagnosis. So imaging is doing a lot of harm because unnecessary exposure to radiations, repeated X-ray, MRI, only if a fracture is suspected, an X-ray or MRI can be the first line of treatment. Otherwise, there are guidelines which we should follow before advising imaging to the patients. That is very, very important. So, if not all this, your question would be, then what will work? Then what should we give the patient in the form of a patient education? So, low back pain education, what can we say? Evidence based. So, here I would quote about what we can say is we have to formulate certain key messages. So, this article, which I am going to present and talk about, is about the key messages. That is certain important information that should be reinforced for the consumers. First, most important is stay active. Staying active is important. You can pace the activities, but you should carry on the normal activities as possible. Staying active will prevent your long-term back problems, and bed rest for more than 2 days is not good. So all these key messages are from a Delphi study defined by French in 2019, of which the link I have mentioned below and also quoted in my references. Reassurance. It's very important that you assure the patient that the pain not necessarily be related to extent of damage in the back. Hurt is not equal to harm. Hurt or pain means that there is certain factor that is pulling your attention towards that particular thing. So, as I said, it can be related to many other factors, to psychological, to behavioral, to social, to physical. So, there can be many factors. So, your hurt is not equal to harm. And pain is such a thing that it settles down over a short time. If back pain persists and worrying you, then you should consult a health professional. That is very important. Acute low back pain will get better in several weeks and it varies from person to person. Low back pain from a very serious health problem like wondering if I have cancer or red flags, it is very rare. So we have to rule out our red flags, but 90% of the cases it does not come from a serious health problem. Most people have low back pain at some stage in their life, and it's not necessary to know the specific cause of low back pain to manage pain effectively. That is why we are talking more in terms of a non-specific low back pain where there is no specific cause. So it is not necessary that knowing the cause will help in an effective management. It's normal to worry about the cause of low back pain and impact it may have, but do not let that worry hamper you and your functions. So your educational material, it should be evidence-based. You have to consider the desire of the patients to satisfy the needs. And a very important point that I got from this particular article was the need to be biased towards beliefs and attitudes that the material aims to influence, regardless of whether patients want to hear the information. So it is not about what patient wants to hear. It is about giving what is ethical, practicing what is evidence based. So that is very important that your educational material has to be consistent with the recommendations. There was an interesting case study that was done in hospital, and they had given patient education based on the CBT principles. Cognitive behavioral therapy is coming up a big way in low back pain. I am not an advocate of one particular approach, but certain points from this particular case study will help to manage the low back pain, or we can use as an example that how we can structure the patient education in low back pain. What are the key areas in which we can work? One is activity pacing, that is managing the activities involving standing and leaning forward. So you can do both the activities, but you can pace the activities. Second important point is attention diversion. It is very important that sometimes patient feels that the back pain is only because at the night. It is because the patient is distracted during the whole day, and the pain what he feels is usually at the night. So you can encourage patient to be involved in certain other activities like exercise classes or some other hobbies. Cognitive reconstructing, that is restructuring, that is a pain physiology education. Or pain does not mean harm. Next thing is the goal setting. So your goals of walking duration, volume, intensity, they are very important when you're giving a home exercise program. A graded exposure, that is progressive walking program utilizing the exercise law. Maintenance strategies, like you can have certain flare-ups, but you can teach the protocol to the patient of how to manage the low back pain and as well as stay active within the limits. Problem solving strategies, like you can teach the patient of how to adhere to a program or how to have a good walking adherence. What can be the postural adjustments that can be done to increase tolerance? But we cannot tell the patient to not work or do not sit for a long time. But what adjustments can be done? How we can cope up with that is the only solution. And so this is what I wanted to say, and these are the references. Please feel free to put in your comments or ask your questions. I will be more than glad if I can make a difference. Thank you. Please subscribe to our channel, The Physio Voice.